Hey, all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you for listening today. Always want to remind you guys, go check out reallifepharmacology.com. Go snag your free 31-page PDF. It's on the top 200 drugs. It'll be a great refresher for you if it's been a while since you've been in school, or if you're taking pharmacology exams, board exams. It's a good little brush-up study guide to make sure you're on top of some of the most important clinical pearls with those drugs. So again, reallifepharmacology.com. Go sign up and you can snag that for free. All right, so the drug I wanted to discuss today is insulin glargine, and it is a medication that I see used very frequently. Obviously, insulin is going to be used in our patients with type 1 and type 2 diabetes. And brand names of this medication, Lantus is probably the one you're going to hear most often. Basaglar is kind of a newer biosimilar agent. And Toujeo is a available dosage form of glargine as well, and that's 300 units per mil, just a little bit different variation on the concentration. So these insulin or insulin glargine is a long-acting insulin, sometimes called a basal insulin, because it really provides kind of a baseline coverage of insulin. It's not meant to manage acutely elevated blood sugars, okay? So it's going to basically bring down blood sugars hopefully pretty evenly all throughout the day. So this is obviously, advantageous in the population that I see most, your type 2 diabetes patients, where it can, bring kind of the, average daily blood sugar down, 20 points or 40 points or whatever the case may be, depending upon the dose you're using and that type of thing. So again, that's going to bring those blood sugars down kind of all throughout the day. So it's not going to be used to target a specific meal, for example. So if a patient is way elevated, after their supper meal, giving Lantus insulin or glargine insulin is not going to bring that down in that setting, or is not appropriate in that setting, because you're going to crash all the other blood sugars as well. And I'll talk a little bit about kinetics and onset and that type of thing too coming up here. If we are using basal insulin, sometimes patients will use a basal plus 1, for instance, in type 2 diabetes. Sometimes they'll do basal boluses, and more often probably found in type 1, where we're giving a bolus dose of rapid-acting insulin, essentially with meals, or when that person has dietary food intake, blood sugar intake. So that's often called a basal bolus type situation, and the basal is obviously going to be the glargine, and then it's potentially being given with a rapid-acting insulin at the meals. The basal insulin, again, only going to be typically dosed once a day. But the reason I wanted to bring that up is sometimes you'll see that insulin split up, or it will be split up into, it's usually approximately a 50-50 split, where 50% of the total daily dose of insulin is going to be basal, and approximately 50% will come as bolus insulin, kind of divided out through those meals, if that's the way it's being given. So that's a question I've definitely come across. Again, it's not always exactly 50-50, but that's kind of a ballpark figure for you. Certainly can vary clinically depending upon the patient. Dose changes I wanted to mention. How frequently do we increase a dose of, let's say we've got Lantus, for example. Usually it's in the neighborhood of every 3 to 7 days. If it's not, a crazy emergency that we need to get down those blood sugars, usually I'm more in the line of 5 to 7 if we can hold off that that long. And obviously, again, this is probably more so in your type 2 diabetes patients. Because again, they've probably had elevated blood sugars for a long, long time. So, being a little bit cautious and making sure we don't get hypoglycemia, that's probably the route I prefer in most cases. But certainly I have seen folks do every 3-day increases as well. So again, just need to monitor those patients clinically, pay attention, and that aggressiveness of increasing the dose, it may necessitate more close clinical monitoring there. It is important not to, at least appropriate, not to do daily increases. Okay, so patients monitoring blood sugars, they're still high. Going up on that dose on a daily basis, you do have the kind of potential to slam them or overload them with insulin, and that could accumulate if we aggressively increase that dose a little bit too quickly. And then again, we're going to raise that risk for hypoglycemia, which nobody likes for sure. Starting dose, it's a question I've been asked before, certainly, so I wanted to mention that. Usually in type 2, I'll refer to the patient population I see most often. Type 2s, usually 10 units is started. That can vary based upon sensitivity or previous trials or clinical decision making based upon where they are. But most often I would say I see 10 units started. Dosed increases, okay, how quickly or how big of an increase do we take? So there you're looking at most often, recommended is in the 10 to 20% range. So if you start at 10 units and you were going to, let's say, 5 days, 5 days a week has gone by and they're still not definitely even close to goal, you're probably going to look to a 10 to 20% increase. So that'd be 1 to 2 units. Now, as we get patients with higher and higher doses, 30 to 40 units, you might increase it to, maybe we do 2 or 3 unit increases. So again, kind of going to depend a little bit on, clinical judgment and have they had hypoglycemia in the past and those type of things. But a good kind of, reference ballpark to kind of start with and think about is the 10 to 20% increases if those blood sugars aren't at goal. And obviously if we don't have much for hypoglycemia risk. Side effect management, so hypoglycemia, I've been mentioning that. The other issue, with insulin kind of on a longer term basis is weight gain. So that is a potential big problem, particularly in patients with type 2 diabetes. They're generally overweight already. So adding insulin can certainly increase that risk of weight going up as well. Conversions, this is a question that I have been asked. Different insurances will require to use, this long-acting insulin versus this product. So I generally always look this up if I get asked on converting one to another. With that said, the majority of or the ballpark, I should say, when we're converting is usually 80 to a 1-to-1 conversion, 80% to a 1-to-1 conversion. So that kind of gives you a little bit of a ballpark. But again, I would encourage you to figure out which individual products we're going to be switching to, whether that's, Levemir to Lantus or, Toujeo to Lantus or whatever the case may be. That 80 to 100%, or close to 1-to-1 ratio is usually where we're at with those. So again, look that up, make sure you got the right conversion there, and then of course clinically monitor that patient closely after any conversion. Okay, I've seen instances where they actually weren't using their particular product appropriately, and then they started the new medication and they did use that appropriately, and that basically ended up in a situation where the dose was way too high. And so patients can get confused, with some of these pen devices and different things. So really, really pay attention in any transition and ensure the patient is well educated, not only to know what to do and how to use it, but also when to report things that are off or wrong and that type of thing, so we can help make a quick intervention before they get hospitalized or something bad happens. Kinetics, I did want to touch on them briefly. So onset typically for insulin glargine is about 3 to 4 hours. So as you can imagine, we're not typically going to have to worry about hypoglycemia right away. Obviously, unless they were, basically hypoglycemic to begin with, it's going to take a little while for that, insulin to be absorbed and to start having its effects over time. Duration of action is obviously going to be around a day. It's usually dosed once a day. I have seen situations, in attempts to try to stabilize absorption, that type of thing, where glargine has been given twice a day, particularly with, Basaglar or Lantus there. Again, that's pretty not a real common situation, but it is something I've seen tried by various clinicians there. How much evidence there is to support that, maybe a little bit questionable. But with that said, duration of action is approximately 24 hours. So typically we're going to be able to get away with once dosing, and that's how it was studied most often as well there. So another thing I wanted to mention was medication errors. This is something I review in long-term care settings, assisted living settings. Medication errors are obviously a big concern with insulin products. Now, with a Lantus glargine type product, that error probably isn't going to be acutely noticed, okay? Because that onset of action is several hours. Compare that to, let's say you give a rapid-acting insulin like Humalog, and you give that, and an error is made with administration in that. You're going to see that issue within 15 minutes, half hour for sure. So that's an important thing to think about. And I have seen errors where patient is on two different insulins, the basal or long-acting insulin and a rapid-acting insulin, and I have seen them switched. And if the rapid-acting is given in place of the long-acting, obviously where that patient is going to be in at a bunch of risk right away within the first half hour of dropping blood sugars and hypoglycemia. So again, really, really important to recognize the high-risk nature of insulin in general. And obviously the utmost care needs to be taken with these products, but it also helps to understand the pharmacology and the pharmacokinetics surrounding these medications in recognizing what's going to happen to that patient and when blood sugars are likely to go down and when they may come back up as well. Monitoring parameters, A1C and blood sugars, obviously what we're going to be focusing on most there. It's not something I would say I worry about to a great extent, especially with the longer acting insulins. But remember that insulin is used as an option to treat acute hyperkalemia. Okay, so that is important to remember, and there is potential there that potassium could be thrown off a little bit. Again, with the longer acting insulins, the slower onset, usually the body has time to compensate. It's not an issue, but that is a good thing to remember with insulins in general, is that they do bring down the serum potassium levels. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for pharmacist board certification study material like pharmacotherapy, medication therapy management, ambulatory care, geriatrics, psychiatry, definitely go check out meded101.com/store, S-T-O-R-E. If you're another healthcare professional, nurse, physician, med student, definitely go check out meded101.com/store. We've got a great list of Amazon books, Audible books. Always remember you can get your first Audible book for free. So I've got books that are between 6 and 8 hours long that you can absolutely get for free if you've never tried Audible before. So again, go check out all those links, meded101.com/store, S-T-O-R-E. All right, finishing up drug interactions. I typically don't worry too much about drug interactions with insulin. Reason being is you're likely going to be monitoring these patients when you make insulin changes. So the one exception is when we maybe add a new medication onto insulin that either might potentiate the effects of lowering blood sugar or potentially mask the symptoms of something like hypoglycemia. So some medications that I think about, obviously, if a patient's on diabetes medications already and we add insulin, we start insulin onto that regimen, they may be a little bit more at risk for hypoglycemia. So any patient taking diabetes medications and we start insulin, we've got to be really cognizant of the fact that, hypoglycemia could certainly happen here. So your metformins, your SGLT2 inhibitors, GLP-1s, pioglitazone, all those drugs may potentiate that risk for hypoglycemia when used in combination. Now, in practice, they are used in combination. Lantus, for example, I see it all the time with metformin. So they are used together, but it's important to recognize when we make changes in those, they could kind of potentiate each other's effects a little bit there. Quinolone antibiotics are a drug that I have seen kind of throw off or alter blood sugars at times, masking hypoglycemia, beta blockers, and that risk. Thiazide diuretics are thrown out there occasionally in the fact that they might potentially raise blood sugars. I don't think they're that significant, clinically significant in most situations, and at the doses that we're often using with thiazides there. Corticosteroids, yes, absolutely can raise blood sugars and really oppose the effects of what we're trying to do with insulin in lowering the blood sugars. Antipsychotics, transplant drugs like cyclosporin and tacrolimus, and stimulants are another example of drugs that may kind of raise blood sugars and kind of counteract the benefits of insulin there. So I think that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed the show, found a nugget or two that you liked, leave us a rating, review on iTunes or wherever you're listening. Greatly appreciative to those of you who have done that. If you want to support this podcast, definitely go to meded101.com/store, and you can check out our whole list of Amazon books, resources for board certification, and all that good stuff. So again, I'm going to sign off for today. Thank you so much for listening, and take care. Have a great rest of your day.